I'm Dr. Spiros Mezidis, now President of the Federation of Hellenic Medical Societies of North America, and I'm honored and it's a pleasure to be here with you tonight. I'll be talking to you briefly about Dr. Papanicolaou. We have left this to the Papanicolaou Society chair people to discuss, but I will be giving you a brief historical overview of the Dr. Papanicolaou Symposia that we've been having here at Cornell for quite some time. It's the 9th continuous year. As you know, Dr. Papanicolaou has been honored for his discovery of the Pap test that has saved millions of women of cervical cancer, and you'll be hearing a lot about that as we go through the evening. Briefly, he was born in Greece and came to the United States in 1913. And he was at the Department of Anatomy here in the city at Cornell for about almost 50 years. He is the founder of the Greek-American medical fraternity that later became the Hellenic Medical Society of New York in the 1920s. The Hellenic Medical Society of New York was founded in 1936. And he is considered father of exfoliative cytology. In 2003, when we started the annual symposia here at Cornell, there was an article in the New York Times and in Times Magazine that spoke about cervical cancer and discussed Dr. Papanicolaou's achievement that you see here, how many few deaths we have nowadays because of this important diagnostic test. And over 50 million American women were checked in 2003 with a Pap test for cervical cancer. Now, Dr. Papanicolaou's legacy here at Cornell has been long, and the affiliation with the Greek American community. You see here in 1979, we have the bust, the unveiling of the statue of Dr. Papanicolaou that's at the entrance from 69th Street. And you see then Archbishop Jacobus here and the dignitaries of that time. In 1998, we have the dedication of the Hippocratic tree at Weill Medical College. And in 1996, you'll hear of the Papanicolaou Society, where Dr. Papanicolaou was born, the society that represents that area from Greece, and started some lecturing that's related to Dr. Papanicolaou's achievements. That was repeated in 1998 in collaboration with the Federation of Hellenic Societies of New York. And then in 2003, with the Department of Anatomy and the Department of Obstetrics, Gynecology here at Cornell, we started the collaboration for the annual Dr. Papanicolaou Symposia. And I want to go through each of these because we have speakers here today who have participated in previous symposia, and I would like to congratulate them and to thank them. In 2003, we had Leopold Koss, the Chairman Emeritus of Pathology from Albert Einstein, deliver the talk on Dr. Papanicolaou Historical Perspective, and Dr. Frank Chervenak, our Chairman of Obstetrics and Gynecology at Weill Cornell, talked to us about ultrasound screening in pregnancy, clinical and ethical dimensions. Dr. Vasiliki Saitas, who's an eminent member of the Hellenic Medical Society of New York and a cytopathologist, she talked to us about evolution cytology. In 2004, the Dr. Papanicolaou Symposium, the historical perspective was given by Professor Demosthenis Triantafylou, who's here tonight, and we thank him for the strong support. Also, Dr. Bibo from Jefferson Medical College in Philadelphia talked about new trends in Pap testing. And our award recipient tonight, Dr. Caputo, as you remember, Dr. Caputo, he spoke to us about new developments in the treatment of cervical cancer. In 2005, Dr. Triantafylou came back to speak to us about Dr. Papanicolaou, a source of inspiration for all generations. And then we have Dr. Zervoudakis here with us tonight, Professor of Clinical Obstetrics and Gynecology, who spoke about early diagnosis of cervical cancer, and Dr. Lorraine Chrysomalis Valasiadis, our gynecologist, who spoke on the Pap smear and update new screening and treatment guidelines for 2005. And we thank him for being speakers that year. In 2006, we had Dr. Elgert from NYU, speak to us about the history of cytotechnology, and Dr. Di Gregorio on control of gene expression in notochord development. And these were lessons from a C-squirt, very scientific, very basic science. And Professor Triantafylou again talked to us of the educational value of Dr. Papanicolaou. Dr. Triantafylou has worked in the Greek American educational system for a long time. He has been at various schools, and at that time was the assistant principal at the Humanities High School in New Jersey. In 2007, we had quite some representation here, as you see, and Dr. Sherman, Dr. Deligori Politi from the University of Athens, Dr. Elgert all spoke on cytology, and then Dr. Nicholas Mezides, the current president of the Hellenic Medical Society of New York, spoke to us about lipotoxicity and treatment of hyperlipidemias, and Professor Triantafylou again gave us a historical perspective on Dr. Papanicolaou, Hippocrates and Dr. Papanicolaou, turning points in the history of medical science. In 2008, again, we had several speakers. On top, Dr. Rigas, who's an eminent gastroenterologist, spoke to us about cervical cancer. And Dr. Hajar, the professor and chairman of anatomy here, in one of several talks during the years of the Dr. Papanicolaou Symposia, spoke to us on angiogenesis in health and disease. Dr. Alexopoulos, who's a psychiatrist, professor at Cornell, spoke to us about antidepressants, and we had a little bit of genetics with Dr. Triantafylos Tafas, talking about prognostic factors of cervical cancer progression. And then from Greece, we had the cytopathology president of the Cytopathology Society and chairman of cytology at the University of Athens, Dr. Margari, talked to us about the Dr. Papanicolaou, a world-renowned cytologist born in Greece. From 2009 to 2011, we continued with our yearly symposia, and there we started presenting the Grand Papanicolaou Award. And you see here the first recipient was Honorable Mr. Dimitris Avramopoulos, at that time Minister of Health and Social Solidarity of the Hellenic Republic. Now he's Minister of the National Defense of the Hellenic Republic. And he delivered a talk on national healthcare systems, comparing Europe and the United States. Professor George Christodoulos, psychiatrist, and at the time chair of the World Psychiatric Association Standing Committee on Ethics, spoke to us on ethical challenges in medicine and psychiatry. Dr. Nasioudziki, who was vice chair and now chair of the Cytology Society in Greece, from the University of Salonika, spoke to us about new biomarkers for the early detection of cervical cancer. And in 2010, Professor Harold Zurhausen, the 2008 Nobel Laureate in Medicine from the German National Cancer Center in Heidelberg, Germany, was here to speak to us about human papillomavirus and cervical cancer. Very memorable talk. In 2011, a good friend of Dr. Chervenak, Professor Aris Anzaklis from Athens, in the Department of Obstetrics and Gynecology at the University of Athens, and Vice President of the World Association of Fertility Medicine, spoke eloquently on screening tests in OBGYN. And Dr. Hajar again, Professor Hajar, the chair of the Department of Anatomy here, continued in Dr. Papanicolaou's legacy, new insights in retinal angiogenesis. So we come to 2012, and where we stand today is that there is a scholarship, a Dr. Papanicolaou scholarship at Weill Medical College. And this Dr. Papanicolaou scholarship was established in the 1990s. In 1998, the Hellenic Medical Society of New York donated $25,000 that were matched by the university. In 2005, again, the Hellenic Medical Society of New York gave a matching gift of $25,000. And this year it has been approved for the Hellenic Medical Society again to be donating for the scholarship $5,000. So we have a fund capital of about $130,000, and it turns out to be approximately $6,000 a year that is given to the medical scholarship recipients here at Cornell. And I want to thank Dr. Marinos Petratos, who's here, who in 1975 established the scholarship funds for the Hellenic Medical Society of New York, and the Hellenic Medical Society of New York has given over $1 million now in scholarships to students of Hellenic heritage through their scholarship program. I want to also show you the recipients of the scholarships from 1999 onwards that you see here, and this year we'll be honoring Carla Canepa, who's here with his family, and thank him. And I want you to look at this. It's from the Hellenic Society of Clinical Psychology that in June will be organizing the international conference related to Dr. Papanicolaou's achievements on the 50th anniversary from his death in 1962. This international conference will be at his birthplace in Kinievia, Greece, on the island of Evia. And Dr. Nasuziki, who has been a past speaker here, has written this on behalf of the Greek psychologists, thanking the Hellenic Medical Society of New York and the Hellenic medical organizations for showcasing Dr. Papanicolaou's work, and Weill Medical College and the other funding societies here, sponsoring societies, for all that they've done for exemplifying Dr. Papanicolaou's achievements. And then at the end here, before we start with the greetings, I would like you to give some thought to the legacy of Dr. George Papanicolaou. He, of course, is a scientist and a hero in medicine, discovered the Pap test, and many cytology societies around the world have his name. There's a research institute that's been established in Miami, Florida, after his death in 1962. And the Department of Anatomy here at Weill Cornell Medical College. We've been very proud to work with the Department of Anatomy. And Dr. Papanicolaou has been here, as I said, almost 50 years as a professor. But he also had the vision of organizing the Greek-American physicians and the physicians of Hellenic heritage abroad by helping in the establishment of the Hellenic Medical Society of New York, that's now 1,000 doctors strong, the Federation of Hellenic Medical Societies of North America that I'm currently president, that was established in 2002, and the Global Hellenic Biomedical Networks, where bioscientists and medical doctors from all over the world have been working together with Greece to improve on the healthcare systems there. So thank you for your attention, and we'll move along here with the greetings. I would like to ask to the podium now Dr. Nicholas Mazidas, President of the Hellenic Medical Society of New York.
Thank you very much, Spiros. I'm going to be brief. We have a long program today. Dear speakers, participants, and guests, friends and members of the Hellenic Medical Society of New York, Dr. George Papanicolaou would be a very proud man attending this evening's event. An event that showcases the institution that supported his career and his research in the United States. An event that provides testimonial to the monumental contribution of his life's work to women's health, as expressed in the words of our awardee this evening and of our symposium speakers. An event that attests to the growth and achievements of the Hellenic Medical Society of New York, whose founding Dr. Papanicolaou inspired and whose activities he proudly supported. I speak for the membership of our society in thanking Dean Glimcher, Weill Cornell Medical College, the Panevouikos Society, the Federation of Hellenic Societies of Greater New York, the Federation of Hellenic Medical Societies, and Xeron Medical Clinical Laboratories for their support of this evening's symposium. I also take this opportunity to congratulate the George N. Papanicolaou Medical Scholarship recipient 2012 at Weill Cornell Medical College, who exemplifies continuity in our profession in the spirit of the Hippocratic Oath. And in closing, I'd also like to mention that there will be the third Papanicolaou tutorial on diagnostic cytopathology again this year in July, which recruits eminent cytopathologists to teach. And I think, Dr. Hoda, this year you have over 90 participants in your program at this institution. So we're very proud that the legacy continues also in the spirit of education. Thank you very much.
Next, we'll have Dr. Catherine Hajar, Professor and Chairman of Anatomy and Cell Biology at Weill Cornell Medical Center, also representing the Dean of the Medical College. Brief our audience.
So thank you very much and welcome everybody. Dr. Glimcher was very sorry that she could not be here tonight, but on behalf of her, our new dean, Dr. Lori Glimcher, and on behalf of the Department of Cell and Developmental Biology, I am really honored and delighted to welcome all of you to Weill Cornell for this special celebration of the life and work of Dr. George Papanicolaou. I hope by now that all of you are aware of just how proud we are that Dr. Papanicolaou was a member of our faculty for some 45 years, from 1916 until 1961. And also I hope you're aware of how grateful we are to all of you for your support through scholarships and gifts. I think it's difficult and perhaps even impossible to pay adequate tribute to the contributions that Dr. Papanicolaou made to medicine and to society. His development of the Pap test, as you know, has saved tens of thousands of lives since it was implemented in the 1940s. And if you add to that the many more thousands who've been saved through early detection of other forms of cancer through diagnostic modalities that are based upon his concept of exfoliative cytology, we can begin to see the measure of his accomplishment. My perception of Dr. Papanicolaou, whom I never had the honor of meeting, is that he was a rather humble man. And I once read that he wrote something in 1930 about his proposed Pap smear test. He wrote, "I failed to create much faith among my colleagues in the practicability of this procedure." And though, however, he was perhaps discouraged in the 1930s, he did not give up. And some 10 years after that, the Pap test came into routine use for the detection of cervical cancer in women. Since then, the worldwide death rate, as we heard, from cervical cancer has dropped by more than 70%. And this is really, I think, one of the greatest public health victories of our time. Indeed, as you know, Dr. Papanicolaou went on to receive many distinguished awards and prizes, among them the American Cancer Society Medal in 1952, the Pisano Foundation Award in 1956, and of course the Lasker Award for Clinical Medical Research in 1959. And I think his story has a great message for all of us. It is that we must have faith in our own work, we must support each other, we must believe in the institution of medicine and in the research enterprise that it supports, even during harsh economic times as we're now experiencing. And above all, we should never give up in our effort to create a better world. So thank you very much for coming this evening.
Next, Dr. Frank Chervenak, Professor and Chairman of Obstetrics and Gynecology at New York Presbyterian, will deliver a meeting.
Nikos, thank you. It's a special privilege to be here tonight. I must admit, I speak with an apology from the Department of Obstetrics and Gynecology, because as Kathy so eloquently presented, in the 1930s, the gynecologists of the time were a little bit reluctant to accept these very, very creative ideas from this crazy Greek who was there. So I apologize for this historical past. I assure you today, under the leadership of Tom Caputo and Kim Holcomb, Divya Gupta, who's in labor right now, Tom Wallace is here. This is part of the distant past. We embrace the Papanicolaou legacy. As Bruce, we're so grateful to be part of this. Thank you so much, and have a good evening. Thank you.
Mr. Elias Tekeridis, President of the Federation of Hellenic Societies of Greater New York, who's been one of the sponsors of this important event every year, will address us now.
Mr. President, Dr. Vizitis, honored guests, ladies and gentlemen, I'm proud to be here tonight with you, honoring a human being, a doctor, a hero, who offers so much to humanity and, of course, to this place here that he served as a doctor. It is with great pleasure when we see in the newspapers that people with Greek descent succeed in all walks of life. And I, for one, when I see a Greek name in the newspaper, I'm elated. But I hope and pray that they do not forget where they come from. They don't forget the roots, the language, the religion, the culture. And I, as a Pontian Greek, and I know quite a few of you don't even know what a Pontian Greek is. My parents came from Asia Minor, was the Black Sea, and we were talking a dialect from ancient Greek, Homer. And I want to leave that to my children and my grandchildren. And I'm talking about you keeping the Greek language. I want to keep the Pontian dialect alive. In closing, Mr. President, I want to congratulate you for what you do for Dr. Papanicolaou and keeping his legacy alive. Also, the scholarship recipient and the honoree of tonight. And continue your good work. Thank you.
Thank you, Mr. Tsigiridis. Next, we'll have Mr. Tassos Ringos, President of the Papanicolaou Society of America.
Thank you, Mr. Mazidis, esteemed guests, ladies and gentlemen. My name is Anastasios Ringos, Tassos is the short, and I'm the President of the Papanicolaou Society of America. Can you hear me good from the, I have to go right close to it. And I'm going to be speaking tonight on behalf of the Papanicolaou Society, and we're especially proud of the man we honor today. And by the way, I was born in Greece as well, and but I came here like 6 years old. I was raised in Brooklyn, New York, and some people would say that's a dialect as well. Next slide, please. Briefly, I'm going to mention some stuff that was mentioned earlier by Mr. Mazidis. Dr. George Papanicolaou was born May 13, 1883 in Kimi, Evia, Greece. I don't need the mic, right? You can hear me. Yes, you do. You do. You do, okay. He died in, oh, you have, no, you don't want to see it. He died in February 19th, 1962, and is buried in New Jersey. Next slide, please. Dr. Papanicolaou, a man of vision who contributed so greatly to women's health to this very day. And as you see, most pictures you see of him, he's with a microscope. That's like his trademark. You always see him with a microscope. This is Evia, Greece. This is the island he was born. Next slide, please. And this is the tip, Kimi, it's called K-I-M-I, the place where he was born. There you go. Next slide, please. And thank God for Google Earth. This is what it looks like. And this is the village where he's at. And his house is, next slide, please, right there. Right there. Which it'll be turned into a museum. All the work to repair and update the house is scheduled to be completed by the end of September 2012. Next slide. The target date to open as a full functioning museum is fall of 2013, so it's coming up. The Institute Papanicolaou will be a reliable provision of scientific and medical information for prevention, diagnosis, and treatment of cancer, provisions of information and psychological support for the patients, provision of financial support and awards for relevant research projects, completed educational programs for health subjects, and of course the construction and success of the Museum of Dr. Papanicolaou. Next slide, please. As you see, in May 18th, 1978, the U.S. Postal Service issued a stamp honoring the late Dr. George Papanicolaou, which is very good success in itself. The history of this symposium was Dr. Papanicolaou was first honored by the Papanicolaou Society of America in 1991 at the Hellenic Cultural Center in Astoria, New York. Of course, sorry. by then President Poppy Venizelos Vlasidis. Professor Demosthenis Triandafilou was the keynote speaker. The Papanicolaou Society of America, which I represent tonight, continued to annually honor Dr. Papanicolaou until 1995. In 1996, the then President Yannis Simeonidis of the Papanicolaou Society of America with Professor Demosthenis Triandafilou came in contact with Dr. Anthony Vasilas, former president of the Hellenic Medical Society of New York, and jointly organized the first Dr. Papanicolaou Symposium in Weill, Cornell Medical Center. The Federation of Hellenic Societies also participated. To commemorate the first symposium, Papanicolaou Society of America had the Dr. Papanicolaou banner made with the date 1996, the one you see right there in front of you. And I thank you for your time.
Now we'll proceed with the honoring of the scholarship recipient, Carlo Canepa of Weill Cornell Medical School, class of 2012. And Carlo is of Peruvian heritage, son of immigrants from Peru, proud of you, who has done very good work at Columbia undergrad and here in medical school. He has been accepted at the emergency room program, emergency department program here, residency program at Cornell, where he will be continuing. And he's done some basic science research in HIV. Carlo, please come up. Carlo will tell us a little bit about what this scholarship award means to him and for his professional career.
So first of all, I want to thank my parents who are here tonight. Thank you for coming out, for your love and support through all the years. Just like Dr. Papanicolaou, they're immigrants to New York. Along with myself, I was also born in Peru and came here with them. So sort of this, we try to embody the same spirit that he embodied by coming here. I also want to thank my brother Luigi and my girlfriend Dorothy, who are here tonight as well. And then to the Hellenic Medical Society, I want to thank you for this wonderful honor. It's always really nice to be recognized for your hard work. I've been very fortunate in that I've received a lot of scholarships throughout my life. I got a scholarship to go to Columbia for my undergraduate. I've gotten scholarships to do research abroad internationally. And now as well at Weill Cornell, I've gotten another scholarship. So I've been very fortunate throughout my life. And I've sort of used those scholarships to give back in whatever way I can. In the past, I've done a lot of international work. I've done research in HIV and AIDS in Rwanda, Liberia. I've done malaria research in Madagascar. And I hope to continue those endeavors as I go into residency. Even though I'm going into emergency medicine, I think the Pap smear test and women's health will be a big part of what my daily practice in the emergency department. So I want to thank you for the opportunity to continue those endeavors. And then on a final note, this award is very important to me as well because my mother is a cancer survivor, in particular of a gynecological cancer. So this is she was treated in the 80s in Peru at a time where medical care was not as available as it is today. So I'm very fortunate that she's with me today and that she survived this cancer. And so, it's true to my heart. So thank you very much.
And at this time, I would like to invite again Dr. Frank Chervenak to the podium to introduce our keynote speaker, Dr. Thomas Caputo.
I'll try to keep my remarks short about this wonderful person, Tom Caputo. He's been with our medical center here, I think, a little over 30 years, where some of you in this room were born. And I think it's fair to say, I know it's fair to say, that he started gynecologic oncology here on this campus at New York Hospital, then the Cornell Medical Center. And sometimes he maintained this single-handedly throughout this time. And I think all of you know gynecologic oncology is a tough, tough business. What's special about Tom Caputo, he's done it with heart. And I'm sure Dr. Papanicolaou is smiling down from heaven and very approving of Tom Caputo. He's a person with human values. He cares about his patients. His patients love him, not just for his competence, but for his care, something that we have to protect very carefully in modern medicine. There's so much more I can say about this great man, who is director of our Division of Gynecologic Oncology in the Department of Obstetrics and Gynecology. Someone I'm proud to call vice chairman. He has the respect and admiration of our faculty, not just patients, but doctors, some strong-willed doctors, but he holds the respect of all. And please, I hope you don't hold two things against him. Although he's a very principled man, a religious man, he's not orthodox. So please forgive him for this. And please forgive him the mortal sin. Although he's Mediterranean and proud of his background, he's not Greek. I'm so proud to present Dr. Thompson.
Well, thank you. I hope somebody's recording that. Show my chairman in some other situations. Well, I've got to tell you, when Dr. Chervenak, Dr. Zervadakis called me in the office and said, good, I hope you can hear me. Well, called me in the office that you've been asked to give a talk at the Papanicolaou Society, Hellenic Society meeting. I said I'd be honored to, and I left and I was starting to think what topic I would talk about. And I had given a talk a few years ago, as you saw, about updated cervical cancer. And about a few days later, my secretary walks in the office and she hands me this. He says, "You know you're getting honored at that meeting?" And I looked at it and I said, "Somebody made a mistake." And it was overwhelming. I couldn't believe it. So I can't tell you how thankful, honored, and humbled I am with this. To have my name mentioned in the same room with Dr. Papanicolaou is just fantastic. So, Mr. President of both societies, members of societies, Dr. Hajar, Dr. Chervenak, thank you for this honor. So I did change my talk, all right, because I wanted to make it personal and I wanted to honor, in my own way, Dr. Papanicolaou. So you have seen some of these slides, but we're going to repeat it, and I'm going to try to emphasize a little bit about what some of the slides are about. And what I would like to talk about is not, we can't avoid talking about pap smear and what it meant to cervical cancer. But the pap smear has opened up, the spin-offs of the pap smear, so many other valuable medical inventions, devices, and procedures for both men and women. And I also want to tell you a little bit more about the secret behind Dr. Papanicolaou's success. Of course, it was a great woman. And so, with that, let me see if I can push the right buttons. Oh, what did I do? Okay. I gotta see if I can.
Use the arrows on the keyboard.
The arrow? Oh, okay. Right, so you've seen some of these dates. Dr. Papanicolaou did die in 1962. He retired from the Cornell Medical College a few years before that. This is a picture of his home. There is now a plaque, and I didn't know from the literature that it was going to be made into a museum. That's absolutely wonderful. I couldn't resist this slide when I saw it. This is for Dr. Papanicolaou looking at cytology slides for any cytopathologist. I can't think of a greater picture, and I just had to put that in there. He was born in 1883. He was the son of a doctor. When he graduated from medical school, he didn't want to stay in a small town and practice medicine. He did graduate school and then became in the Army, was brought into the Army. and was dismissed as an assistant surgeon in '06. In '07 and '10, he went to Germany where he did postgraduate work with some of the great German scientists, which influenced him throughout his career. But the best thing he ever did, in my opinion, he got married to Andromach Marioni, I hope I can pronounce that name, in September 1910. And this is a picture of Mrs. Papanicolaou. This was said about her. She consented to become her husband's first experimental human subject. And you'll see some of his bibliography and what work he did at establishing the human sex cycle, for instance, besides the pap smear and the cancer. He was the source of establishing normal cytology patterns in women. And I don't know how well he's really known for that by many, many people. He introduced his wife affectionately as my wife and my victim. Maybe some truth to that. In March of 1969, she was honored by the American Cancer Society as a companion to greatness, and I think that's very true. And she died in October 1982 in Miami, where they had moved to establish a new research facility. He returned to Dr. Papanicolaou to his hometown, but didn't want to stay there. And he did eventually leave for Monaco, where he had a great position. If you've ever been there, it's an absolutely beautiful, stunning site. He was then recruited to fight in the Balkan Wars, where he met Greek Americans who had come from America to fight with the Greeks at that time, and they told him about America. And they influenced them. They told him what a great place it was, and it was a country of open possibilities. So he decided to come to America in 1913 with his wife. Before he started working at Cornell, he used to play the violin in restaurants and other cafes to make money. He worked at Gibbels, him and his wife also, for about a year before he was obtained the position at Cornell. How he did that, I couldn't find. I would love to talk to some of the old timers to find out how he hooked up with Cornell. He became an assistant professor and then he retired in 1957. Again, I recognize this office. He worked in the basement of below my office in the M building. Okay? I got to tell you, one of the reasons why I worked in the basement, because I did talk to one of the old timers, and he told me he was put there because somebody said his work would never amount to anything. So I could never confirm that story, but it sounds typically like a Cornell. In 1917, he published this paper, A Typical Estrus Cycle of the Guinea Pig. He actually went out and bought a nasal speculum so he could put it in the vagina of guinea pigs and get the cytology. And that's how that started. It's been quoted or cited in the literature 345 times. In 1928, the beginning of one of the most significant papers, in Battle Creek, Michigan, he presented his paper that the vagina can reveal the presence of cervical cancer. And this breakthrough, of course, led to the development of the pap smear, and the stain, by the way, he had to develop as well. And that paper was presented as a very significant date, 1928. In the New York World newspaper, obviously it doesn't exist anymore, January 5, 1920, he said, although Dr. Papanicolaou is not willing to predict how useful the new diagnostic method will be in the actual treatment of malignancy itself, it seems probable that it will prove valuable in determining cancer in the early stages of its growth, when it can be more easily fought and treated. What an understatement. In 1933, he published The Sexual Cycle in the Human Female. I'm not sure, but he must have been taking pap smears on his wife almost every day to correlate the cycle. And the paper was cited 271 times. In 1939, they started doing pap smears on all women admitted to the New York Lying-In. It did move to its new site, I believe, the year before, and that's probably the first screening pap smear program anywhere in the world. In 1941 and 1954, he published two significant papers with Dr. Trout, who was an OB/GYN doctor at Cornell. and eventually moved to California, and deserves a lot of the credit for helping Dr. Papanicolaou obtaining smears correlating with pre-cancer and cancer. His most two significant sentinel publications was in 1941, and this paper has been cited 236 times. And from that paper, he said, and remember the population in the United States at that time was about 100 million, 110 million. Approximately 32,000 deaths from female genital tract cancers, and 4/5, 26,000 deaths, were due to cancer of the uterus. Actually, it was cervical cancer. And the other monograph was published in 1943, which were very, very important landmarks in his work. I put these in because I just really felt, I must admit, I feel just reading them. There were moments of real excitement when the examination of the first slide revealed an impressive wealth of diverse cell forms and a sequence of distinctive cytologic patterns. He was talking about the estrous cycle at that time. And then this, the first observation of cancer cells in the smear of the uterine cervix, was one of the most thrilling experiences of my scientific career. I could well understand that as the history goes forward. What an important thing to be able to look back on and remember. In 1960, Dr. Pap was nominated for the Nobel Prize 5 times. He never received the Nobel Prize. Reasons unknown. He did retire from Cornell at 1957, I believe, and then went to Miami to set up this new institute. I don't know how that came about. Again, I couldn't find from all the literature. I kept reading more and more and more. It was fascinating. I couldn't find how that came about. Some of the articles I read were written by his young associates that were going to Miami with him. And unfortunately, he died February 19th, 1962 in Miami. He was buried in Clinton, New Jersey. There's a picture of his cemetery plot. And you've seen this one, the sapling from planted in Cornell in 1978. And this one you've seen before, but this is a very important picture for other reasons, because the medical students go by this bust, and I asked them, who was Dr. Papanicolaou, and they said, it's the gentleman with the bust in the hallway. And then sometimes I have to ask them, who is Dr. Papanicolaou? I'm not kidding. And sometimes you get blank stares, but that doesn't last very long, I assure you. So in 41, again, 43, we mentioned those papers, but the spin-offs, the other people who got into the research, you don't know Dr. Miggs, he was a great radical surgeon. Ruth Graham was a great cytologist from Boston, but they were probably the first ones to confirm Dr. Papanicolaou's work. Yeah, we could find cancer cells on these smears. Dr. Hare worked with there's so many great people that trained with Dr. Papanicolaou and went out all over the country. There's no people, not very well known. Dr. Hare is a hair spatula, was here with Dr. Papanicolaou. Dr. Papanicolaou's technique was an aspiration technique with a bulb syringe. It didn't work that well. Dr. Hare invented the air spatula, which made it much easier to get a pap smear. And also described the histologic changes of HPV, but they didn't recognize that HPV at that time was the cause of dysplasia, condyloma, and eventually cervical cancer. Formal training programs in cytology began in the 1950s. In 1956, Dr. Koss, who you saw mentioned, first described coilocytotic atypia, which to all of us has a great meaning. In 1960, Ayres suggested a virus may be causing these pap smear changes or cell changes. 1976, 2 French doctors correlated their pap smear with condyloma and believed that the condyloma were caused by the HPV virus. And again, this is all work that would have never probably occurred if it wasn't for Dr. Papanicolaou not only pursuing the cell changes, but the idea of cytology and screening. And in the 1980s, we'll talk a little bit more, the science, the specialty of aspiration cytology started to develop. And this is all because of the pap smear. Development of automated cytology, which you're going to hear about tonight, both from Dr. Caputo and our other speaker. And finally, in 08, as you heard, Dr. Zarhamson was given the Nobel Prize for discovering that the HPV virus was actually the cause of cervical dysplasia, as well as the cervical cancer. This is an example of a pap smear for those of you who don't do pap smear brush or cyto brush. It's one type of brush. This is not the air spatula, in which we collect cell samples. Cervical cancer mortality in the United States has decreased over the last 5 decades, 50 years, by over 70%, in large part to the introduction of the pap smear. Nobody argues with that. That's an incredible amount of lives saved. But I would propose that more lives have been saved because of not just the pap smear and finding dysplasia or cancer, but all the other attributes or spin-offs of the pap smear that I'll go into in my later slides. It was the most common cancer deaths in U.S. women in the 1930s. And so we've come a long, long way. In the 40s, the incidence of cervical cancer in the U.S. was estimated at 33 cases per 100,000. At the present time, it's about 7 to 8 cases per 100,000, a tremendous difference. Over the last 40 to 50 years in developed countries, countries that use the pap smear, the screening of sexually active women annually, or once every at least 2 or 3 years, resulted in a significant decrease in cervical cancer incidence and mortality. These are different quotes from peer-reviewed articles. Cytology-based cervical cancer screening has dramatically reduced the burden of invasive cancer, and the pap test is now recognized as the most significant advance in the control of cancer in the 20th century. That's a pretty strong statement about anything, about anybody. This is what the trends look like. If you look at the top, this is from the 30s, the dramatic drop, but notice no change in ovarian cancer, pancreas cancer, unfortunately. Slight drop in colon cancer. Why? Screening based on Papanicolaou's idea that you could screen, find preoperative cancer, pre-cancer, and treat it. All over the world, except for Korea, and I can't find the explanation why that went up. There's been a dramatic drop, except for Russia and Europe. And unfortunately, I don't have Greece there. It wasn't included in the literature that I could find. But in every developed country where the pap smear has been used, there's been a dramatic drop in cervical cancer. In the world, in 2011, there were 530,000 new cases of cervical cancer, and 275,000 women died from cervical cancer in the world. This accounted for about 15% of all female cancers and 8% of all female cancer deaths, respectively. And that's in the world. This is the American Cancer Society list of cancers in 2012, and as you can see, or you may not be able to notice, the number of cases, number of deaths is not even listed. It's way down here. And certainly the majority of that is because of screening, finding not only cancer, pre-cancer, treatment, prevention from it ever going to cancer. Worldwide, cervical cancer is the 4th leading cause of death. In the developed world, it is not even in the top 10, as I showed you. But in the developing world, where women aren't screened, the poor countries, it is the 2nd leading cause of death even today. So what we're talking about, what Dr. Papanicolaou did was spectacular. So it's very sad and unfortunate circumstances. And this is what it looks like. Again, there are incidents of women of various ages, a steady drop as screening increased over the years. In the world, if you're interested, if you could read, that's a little small, but you can see the purple areas, such as the United States, Canada, Australia has a tremendous screening program where their incidence dropped very dramatically. Russia, you can see, Africa, South America, extremely high rates of today cervical cancer, simply because there are no effective screening programs. A tragedy. Nothing needs to be discovered. We're going to talk about computers, artificial intelligence, Dr. Hoda and our other speaker shortly, so we'll look forward to that. But that all came together and all progressed again because of the pap smear. The incidence of cervical cancer is reduced. It's a powerful reduction because of the pap smear. 93% if you have a screening every year. It drops to 60% if you're screened every 10 years. Hopefully, most women are being screened at a regular interval of between 1 and 3 years. Despite this intensive cytologic screening, cervical cancer remains a significant cause of morbidity and death in the United States, with more than 12,000 incident cases a year and more than 4,000 deaths, which is minute compared to what it was. Now, how can this be? We have all this screening, everybody has vans. Why is it that we see cervical cancer? It's kind of a little bit of a tragedy. The National Institute of Health, and I lecture this, people challenge me all the time, estimates that only half of women who receive cervical cancer diagnosis have never been screened. People don't understand that. 50% of our women, there are reasons for it. Of course, poor population, immigrant population, all kinds of reasons. But 50% have never been screened. And an additional 10% have not been screened in the previous 5 years. And as any of the oncologists will tell you, they're usually the women we see with very advanced cancer and the women that we can't salvage. So the pap smear and the HPV screening and persistence of HPV is a critical factor in the development of cancer. Women who are diagnosed as a result of a smear have a better prognosis than women whose case is detected on the basis of symptoms. As clinicians, we all know this. The patient comes in with bleeding, pain, it's usually advanced disease. If it's found on a pap smear, it's most often much earlier and easier to treat. This is what it looks like on the curve. So it's very simple. High cure rates. This could apply to any cancer that you know. Extremely high cure rates, early stage, very poor cure rates, found late. Most of these women have never been screened. Stage 1A is the earliest form of cancer, but it's even better than that. Carcinoma in situ, we call stage 0, or dysplasia, which occurs 200,000-300,000 times a year in the United States, and picked up by the pap smears, are entirely curable. These women, many of them would be developing cervical cancer if they had never had a pap smear. The pap smear has survived virtually unchanged for 50 years and is a testimony to its efficacy. And you're going to hear about liquid-based cytology and automation in our next lectures. And women around the world, in some general statements, have developed great confidence in the pap smear or cervical smear, and I think that's true. The largest gains in reducing cervical cancer incidence and mortality can be obtained by increasing screening rates. We know that. It's easy to say, it's hard to do, among women who are currently unscreened or screened only infrequently. There are many advertising campaigns and various signs every woman should. So the public is generally aware, and to this day there are 30 women who are diagnosed with cervical cancer every day. Most of those women have either never had a pap smear, have never had one for 5 or 10 years. So these are preventable deaths. Now, the other issues that I think have saved more lives than the actual pap smear maybe in picking up cancer is that it's responsible for the concept of screening. Dr. Pap in screening was the first screening test of its kind, the first concept that you could find cancer pre-cancer and that you could do something about it and you could prevent it from ever going on to cancer. So that all stems from his research and work. And from the other screening programs, such as a mammogram. Find the lesion early. But you could do these programs, that it would work. Colon cancer, polyps, adenomas, you find it early, you can treat it, prevent the cancer. Lung cancer, CT, chest, a little controversial. Ear, nose, and throat, dental screening, skin screening. These are all stemmed from the first screening and epidemiologic type of its kind. Again, the pap smear and Dr. Papanicolaou propagating and developing that work. Part of that was only discovering the pap smear and recognizing the cells, but putting it into a screening program is probably maybe his greatest contribution. So cervical cancer serves as the model for all screening programs. And as we already noted, there's been a major decrease in cervical cancer. The smear led to the concept of cytopathology. Okay? The use of needle cytopathology for the diagnosis of cancer. Just about, as far as I know, every area of the body has had to put a needle into it. There may be some I don't know about, and I'd be happy to learn. But just think of it. The smear, you can call it a pap smear, you can whatever you want, but you can put a needle into any area, take out some cells, put it on a slide. This all comes from the concept of screening and developed through the work at Cornell. The other benefits of going for a pap smear may be more important than just about anything. Going for a pap smear is a socially acceptable reason to go to your doctor. You can tell your husband, I'm going for my pap smear. You can tell your friends, I'm going to your pap smear. You don't have to explain anything. Everybody knows. All right, but going for that pap smear is more valuable than the pap smear itself. The patient gets an exam. The patient will be screened for sexually transmitted disease, has a breast exam, I would hope, a pelvic exam, has their blood pressure taken, if nothing else, can discuss family problems, as they often do with their OB/GYN. It's usually a very close relationship. Abuse problems will often come out. Sexual problems will often be discussed. And then the patient is referred for what? Other screening programs. She's referred for her mammogram. She's referred for her colonoscopy. She's referred. So that may be more valuable and probably has saved more lives than maybe the actual pap smear itself, in my opinion. But they would have never gotten there or get into a screening program if they didn't go see their doctor for their pap smear. The pap smear led to the discovery of the HPV, which is, of course, critically important. Suspected viral changes were described by Dr. Papanicolaou, Dr. Eyre, Dr. Koss, I think as you know, Dr. Meisels, important from Canada, and finally Dr. Harold Johansen, who won the Nobel Prize for discovering the fact that HPV causes cervical cancer. And through that, all stemming, again, I say, from the screening program and the development of smear, and then eventually the HPV and the discovery of HPV as a cause of cancer came the vaccine. And viral changes and the development of a HPV vaccine, and the two vaccines, Gardasil, Cervarix, most commonly used in this country is Gardasil. But the point I want to make is just think about it. Just think about it. There is a vaccine that can prevent cancer. That it doesn't cure cancer, but it prevents cancer. And it has the potential, if uniformly applied, of eliminating cervical cancer, genital warts, dysplasia. It's, when you think about it, it's absolutely amazing. This is just a curve to show that if the Gardasil, the vaccine, gives lifelong protection, it's extraordinarily effective. If it's not, this is a theoretic slide, depending on when you give the vaccine and how potent it is. We're not sure how long the effect of the vaccine is at this point, whether booster shots will be necessary. But it has to be applied early and often. I think that's one of our problems, getting our population to inoculate. My granddaughter, who's now 3, and that's the proper time to do it. But convincing my daughter to have my granddaughter get Gardasil vaccine is not really necessary because she's never going to do that. So anyway, that's part of the social problem we have to deal with. And also it's available for men now. And you got to give it when it's most effectively as young men. It's approved at 6, but it should be given much younger. And if we can get both the female and the male population effectively vaccinated, we can eliminate cervical cancer. It's outstanding. I don't know of any other cancer that we can say that about. And finally, cancer screening, because of the invention of the finding of HPV, and because guidelines have been changing. I won't even try to explain it because I don't understand it. But if you utilize the HPV plus the pap smear, you can spread out your pap smear intervals. You can save billions of dollars with the cost of a few lives. And now they recommend we started screening at age 21 for all patients, except for the 19-year-old I just saw in my office. I don't understand. But so there's a lot of controversy, but if you're involved with this, you're going to see a lot of changes over the years coming by all the societies. So to save more lives, we have to do more screening. We have to apply the vaccine that's available. And the screening test, no matter what, remains an important strategy in cervical cancer control in the HPV vaccination era. So it hasn't gone away, and it won't go away, maybe forever or for a long time. Finally, in 2012, the Gynecologic Foundation and Gynecologic Oncology Foundation honored these men. Dr. Zerhounsen, you know about. Dr. Nobles is a virologist at NIH who helped develop the vaccine. And finally, Dr. Papanicolaou and Dr. Trout were honored by some of our Society of Gynecologic Oncology this year for the first time. And of course, the stamp you're aware about, but I do want to give special thanks to the archivists, the people who pull out all this material, all this wonderful history. It's fantastic. And to Helen Epstein, our clinical librarian, who put all this together for me, helped me get the literature and everything else, and helped me put the slides together for me. So with that, again, I thank you for this wonderful honor, and I appreciate it.
At this time, we'll present Dr. Caputo with the fourth Grand Papanicolaou Award of the Hellenic Medical Society of New York.
Just walked out, yeah, for all the work that she's done for the archives here for Dr. Papanicolaou. And I would also like to let you know that the Hellenic Republic has put together some funds for a film on Dr. Papanicolaou on the death of the 50th anniversary of his death. And the producer and your helper here tonight from Athens, Ms. Nicole Alexandropoulou, and I'll be here, and thank you for being here. So they're taking notes on everything that we're saying. And they'll be included in the film that will be of international acclaim. And we'll continue with our scientific program with Dr. Rana Hoda, Professor of Pathology and Director of the Papanicolaou Cytopathology Laboratory here at the Weill Medical College. She will be speaking to us on advances in Pap testing. Thank you, Dr. Hoda.
So the topic is advances in Pap test psychology. Again, we are gathered here to celebrate Dr. Pap's life. Dr. Pap, of course, a pioneer of cytopathology, and it's dear to our heart because I am a cytopathologist by profession, and he was the inventor of Pap. His parents. So, brief history, I know we will have touched on his personal life, and Dr. Caputo did make my work easier, so it's going to go much faster. These are Dr. Pap's parents, Nicholas and Mary. And again, Kini, the town in Greece where Dr. Pap was born, his home, as you've already seen, and we would love to go in 2013 and visit the museum. Dr. Pap at age 13. This is Dr. Pap at 20 when he was a senior medical student. Appreciated the skull in it that he's holding. Dr. Pap when he fought in the Balkan War, when he was serving the Greek army. And this is a year later, as Dr. Caputo gave the detailed story about how Dr. Pap landed in the United States. So here he is with Mrs. Pap, of course, his lifetime companion and his strongest supporter of his profession and personally. So I'm sure that you all have read this book by Mukherjee, who's at Columbia, entitled The Emperor of All Maladies, a Biography of Cancer. And in that he writes that Papanicolaou was penniless of the books. He was relegated to selling carpets at Gimbel's to survive. By all accounts, he was a terrible carpet salesman, and he finally secured a research position at Cornell. And there he is. So, of course, he was relegated to studying the menstrual cycle in guinea pigs, which, if you're aware, is the most difficult thing that one can accomplish because they don't menstruate like humans. So he had to study the cells and follow the reproductive changes and the menstrual cycle changes that occurred on a daily basis. And of course, then he expanded his work to women And in 1928, when he presented his work in Battle Creek, Michigan, the Michigan doctors were skeptic and they did not, of course, receive it well, but it did make headlines. And here is what Dr. Caputo had showed, New York World. A New York doctor finds cancer detection method. And so this made news in Pap smear, made news in 1928, and it's still making news. This is an article that was published a couple of days ago in the New York Times, where I don't know if you're aware of this show by HBO called Girls, and the title of the article was HBO show Girls adds to the muddle on Pap and HPV tests. Dr. Pap, of course, won a lot of awards, and Elizabeth and Liz, the two gracious ladies who work for the Cornell archives, just said that they found a lot of medals that Dr. Pap had received, which they were not aware of until very recently. So they'll all be put out for the exhibit. You know that the library has the two showcases outside the library. That exhibit will be there till July. So here's Mrs. Pap working at Cornell, and it was, somebody said Dr. Pap was here since 1916. I think Mukherjee had said 1930, but he was here for a long time. And of course, Dr. Pap, as a family man with his sister and wife, and this is their last visit to Greece. And this picture of Dr. and Mrs. Pap is supposed to be the last picture taken in 1962. So Dr. Pap, looking at this beautiful page from his atlas on exfoliative cytology, these pictures were painted. They're hand-painted by a Japanese artist. And of course, they had a special photographer who also took some pictures of the cells. And the most astonishing thing is, if you look at his original atlas, which is a loose-leaf atlas, and it's not published anymore. We have his original atlas in our lab, plus we also have some reprints. So even today, we're looking for the same cells when we look at, we're looking for pre-neoplastic or neoplastic changes in the pap. We still describe this cell as a tadpole cell, coilocytotic change. All the lesions or the morphologic changes that we had been presented by Dr. Pap in 1944. So this is when, after his atlas on exfoliative cytology was published, Dr. Pap laid the foundation for our subspecialty. That's when cytopathology became a real entity. And so New York Hospital had sort of, after 1928, things had become quiet and Dr. Pap wasn't talking too much about his research. So the hospital revisited and started to reevaluate the value of screening. And so from 1939 onwards, the vaginal pap, as it was called, was routine for all women admitted to the hospital, and Dr. Trout and Dr. Pap then put their work together. And at that time, the name of the test changed from vaginal smear to pap smear. And as many of the speakers have pointed out, the pap smear led to a 70% decline in the incidence and mortality of cervical cancer in the United States. So it became the most successful cancer screening test in history, and cervical cancer now ranks 14th in cancer deaths. So it's was not even in the chart that Dr. Caputo showed us. Currently, more than 50 million pap tests are performed each year in the United States. But look at this number, only about 3.5 million paps are abnormal. So we're looking for a needle in a haystack. And the breakdown, if you look at the breakdown, the unfortunate thing is that majority of the abnormalities are changes that we really don't know the significance of. So we call them atypical squamous cells of undetermined significance. You don't know if this is a benign entity or this lesion can progress to invasive cancer. And that constitutes the majority of the cases. We have about 1 million low-grade squamous intraepithelial lesions. and about 300,000 high grade, which are the true pre-neoplastic events to invasive squamous cancer. And we still have in this country about 12,700 cancers occurred in 2011. So when we as cytopathologists or cytologists are looking at a PAP, we have to look at all these items. And it's a gruesome and a tedious and a very serious time when the slide is the microscope. And this by no means is a complete list. So let's briefly touch on the advances in PAP test cytology. They're listed here. So the preparation types changed to liquid-based preparations in 1996, and these are dates with Fda Approved. The classification system and the reporting of the PAP diagnoses changed in 2001, and automation was brought in 2003. Hpv test also became available in 2003. Management guidelines were then issued based on all the studies that were done on automation and liquid-based preparations and Hpv testing, and there are numerous algorithms for nearly every abnormality that can be encountered in a PAP were published. This was first done in 2006, and Hpv Vaccine also became available in 2006. So Dr. Pap said almost more than 50 years ago, the validity of the PAP screen depends upon experience and skill of cytologists, adequacy and preservation of specimen, and proper preparation and staining of smear. And it's true even today. So previously, the PAP was collected using the iron spatula, which was a wooden spatula, and then the specimen was smeared on a glass slide, and then the collection device was discarded, and the slide was reviewed on the microscope. And studies show that when you collected smears with these devices, the diagnostic cells, so the blue is supposed to be the abnormal cell population. In about, in many cases, almost 80% of abnormal cells fail to make it to the glass slide, and it's thrown off without anyone having looked at it. So the way the PAP was collected and prepared changed, and these were the new sampling devices, broom and a brush. And we are still getting more innovative devices. So this is a combo of a brush and a broom. And the idea is that the tip should be in the endocervical canal, while the bristles of the brush should be around the ectocervix. Am I right, Dr. Caputo?
Correct.
So here is the cervix showing dysplasia, and then the brush or broom is twirled. It's then rinsed in this proprietary collection medium and transported to the lab. So currently in the market there are, I don't want to bore you, but two types of liquid-based, and we use thin prep, which is used about with 70% of the labs in the country and the world are using the technique that we use. So pap smear became pap test. And I just want to show you, so conventional smear, liquid-based. And you can appreciate it by using the analogy of these beautiful paintings by Cezanne. So in a conventional, this painting, the fruit is strewn all over the table, and it's kind of difficult to appreciate everything and enjoy the beauty. But in the other painting, the fruit is nicely put in a bowl, and it's eye-catching. So the same thing happens with the conventional smear, where the cells, almost 500,000 cells or objects, will be present in this 2.5 centimeter length of the glass slide, while in liquid-based, they are contained in this 20 millimeter diameter circle in a monolayer fashion. So let's talk about classification and reporting. Dr. Pat used a class system, so it was class 1 to class 5. And of course, like with everything, classification systems, 1 was great, 5 was great, and the in between were a bit problematic. So in this report, Dr. Pap is describing atypical diagnosis, and he says, it is likely that the patient has an early malignant cervical lesion which is progressing slowly, and he called it a class 3. So the classification and reporting system was changed in 2001. The NCI sponsored a huge consensus conference, and terminology was approved. Sorry, a few things changed in my talk because of the PC to MAC transfer. But these are the categories in the squamous abnormalities. We have the atypical that Dr. Papp, when you saw the report, atypical cells where we cannot exclude a high-grade dysplasia, low-grade and high-grade, and of course, last but not least, invasive squamous cell cancer. So Dr. Papp's report corresponds to our current diagnosis of aspis, where we see cells that are cells that look like low-grade squamous intraepithelial lesion, but they're not fulfilling all the criteria, and there's a list of criteria that we have to go through. So this is aspis. Automation cytology was FDA approved in 2003. This was the first system. It's the thin prep imaging system, and this combines the power of computer-assisted screening with human experience in interpretation. So combined, it really does well. And what happens is that slides are loaded into the machine, and the thin prep slide that I showed you has about 80 fields of view. And the machine or the computer will select 22 most important fields that it thinks should be looked at by a human. And so we put it on an automated microscope, and this microscope will automatically take us to those 22 fields that the computer selected, and then the human being decides if this is something that's significant or it's nothing. So it has increased productivity, it has increased sensitivity, and also eased some working. This is what we're looking for, that is CIN3 or carcinoma in situ, which is the true neoplastic event in a pap. Then, up till now, as Dr. Caputo also said, we were working on the light microscopic level. We knew that HPV is out there and it is present in cervical cancer. Dr. Meisel's had, in 1989, he had done a simple EM and he found viral particles in the cells from the cervical smear. But we really didn't know what was HPV actually doing and how it was not doing anything in millions of women, while in a small percentage it was causing invasive cancer. So this landmark article was published by Weill and Shipman and in the journals, where they concluded that virtually all squamous cell cancer of cervix contain one of 15 types of high-risk virus. In this schematic, the authors explain how HPV in the initial infection, when it's just causing a transient infection, it stays in the episomal form. In that form, it does not integrate into the human genome, but it just produces mild cytologic abnormalities, and in more than 90% of women, it will regress in about 2 years. In a small percentage of women, when it's high-risk virus, and in the presence of the right cofactors, the virus may persist and then may progress in a still smaller percentage to invasive cancer. So 40 HPV types infect genital area that cause approximately 6.2 million infections in the United States each year. Type 6 and 11 cause the genital warts, and 15 are oncogenic. Of these 15, 16 and 18 HPV type are the most common in cervical cancer. So this is a schematic that I've taken from a book by Dr. DeMay, and it describes the cells that we look for in a pap smear. And the two things that you can note is that as the cell becomes of greater degree of dysplasia, the nucleus to cytoplasmic ratio increases, and the nucleus becomes darker, bigger, and more significant looking. with the discovery of the HPV and with our knowledge of how it works in causing cervical cancer, the schematic has completely changed. So here in the episomal form, the virus multiplies, but it will not become part of us. When it does integrate into the human genome, the virus stops reproducing or replicating, and now it can persist, or it can regress, or it can progress. It all depends again on the cofactors and the risk factors. But its two oncogenes, E6 and E7, can then play havoc on the cell cycle and lead to the unregulated cell proliferation and neoplasia. So in 2003, FDA approved HPV tests. This one is the primary HPV, where all you do is in women who are more than 30, they will have a pap smear, and an HPV test will be collected in this special medium. And then they will have the HPV test results and the pap test results. If both are negative, the women can come back for a repeat pap in 3 to 5 years, because the chances that they will have a significant pre-neoplastic event in this interval are so minuscule that the screening interval was increased. The next FDA approval was for a reflex HPV test, which is done whenever we see atypical paps. The remaining specimen is sent for HPV testing, and then the patient management depends upon the HPV test results. So if the test is negative, the patient can come back in a year. And the algorithms are on the website. I'll show you that. So based on everything, the American Society of Colposcopy and Cervical Pathology published the guidelines. And this is algorithm for atypical cells, where the most sensitive and sort of inexpensive is supposed to be the HPV DNA test, which will detect HSIL in about 93% of the cases. And this is what we currently do. So all cases which are atypical are reflex to HPV testing. And the guidelines were revisited in 2011, and they were updated. And the update is particularly in the management of adolescents and young women with abnormal cytology and histology. So now the screening will start at 21. There won't be any HPV test till age 29, and then the HPV kicks in after they are 30 and more. And anybody who's interested, the paper has been published in American Journal for Clinical Pathology. And sorry, I have to say this. So these three societies are now combined in looking at the management: American Cancer Society, ASCCP, and ASCP, which is one of the largest pathology organizations. And then the vaccine came in 2006. The first one was a recombinant vaccine, Gardasil, guard against cell. And it consists of 6 and 11, 16 and 18. And in the clinical trials, it was shown that the vaccine prevented 100% of cervical cancers, precancers, and invasive carcinomas associated with HPV 16 and 18. So these two together cause about 70% of squamous cell carcinomas. The remaining 30% are caused by other high-risk viruses. So pap test is a medical triumph. No other test has been as successful as pap test in preventing cancer. And now pap test has entered the era of personalized medicine with targeted management. I'm part of the Papanicolaou cytology laboratory at Weill, Cornell, and I just wanted to assure all of you that we are still carrying on the mission of Dr. Pap. And so we have such a pathology fellowship training program. We train one fellow each year and many residents. 4 books were published from our section in the last 5 years. We have many cytology educational courses where our faculty speak, and this is national, local, international. As Dr. Lizzie just pointed out, we have the annual Papanicolaou tutorial on diagnostic cytopathology at Weill, Cornell. It's now going to be in its 3rd year, and then several other courses. We've had about 50 plus publications in prestigious scientific journals from our section in the last 5 years. So this is our tutorial. We have very prestigious and honorable faculty who's going to be presenting this year, and I'm very grateful to Hellenic Medical Society and Dr. Mesitis because you are the co-sponsor this year. Thank you. So in summary, we can move on to summary. So we are trying to look for the early cancers when they are still at this acute racinoid stage, and we do not want to see invasive squamous cell carcinomas. So I want to end my talk with this story from this book by Scrooge. The book is entitled The Immortal Life of Henrietta Lacks, H-E-L-A. So in 1951, at the age of 30, Henrietta Lacks, the descendant of slaves, was diagnosed with cervical cancer. Her doctor took a small tissue sample without her knowledge and consent. A scientist put that sample into a test tube, and though Henrietta died 8 months later, her cells, known worldwide as HeLa cells, are still alive. H-E Henrietta L-A Lacks. HeLa cells became the first immortal human cell line grown in culture and one of the most important tools in medicine. HeLa cells help develop polio vaccines and treatments for herpes, leukemia, hemophilia, and Parkinson's. It uncovered secrets of cancer and effects of nuclear bombs, and led to cloning, in vitro fertilization, and gene mapping. Since 2001, 5 Nobel Prizes have been awarded for research involving HeLa cells. So this is the Empire State Building. We all know how tall it is. HeLa cells can fill 100 Empire State Buildings. And that is the power of squamous cancer. Thank you.
Thank you, Dr. Hora. Excellent talk. Thank you, and also check and support of the symposium.
And our last speaker, Dr. Petros Tsipouras, Chairman and CEO of Econosis, will talk to us about expanding the horizons for Pap testing.
Thank you, Dr. Tsipouras, for being with us tonight. Invited to present the Papanicolaou Symposium. And as you heard, Dr. Papanicolaou epitomized humanity, humility, brilliance, and persistence. And these are some of the attributes of Greek culture. I know that Greece is actually in the news regularly the last couple of years. Sometimes in a positive, most of the times in a negative picture. But I would like to remind all of us that certain basic values actually emanated from that civilization. And Dr. Papanicolaou is actually epitomized several of those values. So the previous speakers made an excellent job in describing cervical cancer and the screening for cervical cancer, which by all accounts is the most successful screening prevention program worldwide. The fact of the matter remains that in this country we still have 12,200 cases diagnosed every year, and we still have more than 10 women dying of cervical cancer every day. So, although we have made enormous progress, we still have some way to go. And in my talk, I'm going to actually present some approaches as to how we can possibly decrease that number and get to a much better outcome. Of course, the medical cost, and one would argue that it is money well spent, it's approaching to $6 billion, and about $4 billion of that, 2/3 is associated with the screening, which in this country is primarily cytology-based screening,
and $2 billion it's more or less associated with the management. So the pap test is a wonderful test, but if we go down and look at the basics, the sensitivity of the pap test is around 50%. So the trick here is that in order for the pap test to be successful, it needs to be administered regularly. And if we do that, then we increase significantly how many high-grade displays of cancer we diagnose. And as you can see here, we have several large studies, meta-analysis, which more or less give us about the same result in terms of the pap test sensitivity. It's about 1 in 2. Now, Dr. Caputo, I think, alluded to as to, yes, we missed some cancer. Why? At least in this country, why we missed that cancer? There are 2 studies. One is from the Kaiser system in Northern California. The other one is from Sweden. And strikingly, they give us very similar results. And as you can see here, 56% and 64% respectively was due to the fact that there was no recent screen. And recent screen is was defined between 4 months to 50 months. And that was in a population, Kaiser population, that was from 1995 to 2000. In Sweden, I think it was in the early 2000. But the numbers are strikingly similar. Number 2 cause or reason for missing a cancer is pap detection failure. And Dr. Hoda actually will tell you that a number of that is translating to the fact that what had been diagnosed as normal actually was not normal. And so we're not going to go into that. And of course, 13%, 1 in 6, is failure to follow up. So this is the reason, these are 3 reasons why we still have 12,000 of cervical cancer in this country diagnosed every year. So these are the new screening guidelines, and I'm not going to spend any time about the screening guidelines. The only reason that I'd like to put here is that I must say I'm not a gynecologist, I'm not a pathologist, I'm a clinical geneticist, but for the average country doctor, it is actually a bewildering change of screening guidelines. Now, you can see what is the United States Preventive Screening Task Force, and of course the American Cancer Society and ASCCP and American Society of Clinical Pathology. But the bottom line here is that with the latest guidelines that were published earlier this year, we have longer screening intervals. So that is a fact, and I think we are going to be facing longer and longer screening intervals. Now, what is going to be the effect on cancer prevention is something that needs to be seen. And the other part, I think Dr. Caputo alluded in his talk, is the annual pap test is hardwired into the woman's brain, and it's more or less like the mammogram. How we are going to be able to convince the patient, the woman, who has consistently benefited from that, to go into longer screening intervals, I don't know how easy it's going to be, but that's what is the recommendation. So, Dr. Hoda actually alluded to the fact that, yes, that's the screening, that's what we do. But in essence, what we are trying to do is, where the screening is going is towards risk stratification. That's what we're trying to do. Here is the spectrum of what we see, and this is the combination of cytological and, of course, HPV typing. But this is easy, so we know what to do. This is easy, we know what needs to be done. This is the part that actually needs to be addressed effectively.
And this is where risk stratification comes. And what is there to be able to more effectively diagnose those cases that are destined to progress and separate them from the majority that is going to more or less regress. Now, a new development, or something that is we're going to see in this country, is the introduction of HPV screening. So, Pap test is the primary screening modality in this country, and actually to that effect in most of the world where it is administered regularly. What we see right now is that HPV, at least in some European countries, is going to be introduced. In fact, it has been introduced in Netherlands as the primary screening modality. And that is going to actually change the dynamic in terms of what we diagnose, how frequently, what is the interval, and even more important, how we deal with the large number of positives that we're going to be seeing. So the idea is not only to do the screening, the idea is how you are going to deal with the positives, the screen positives. And as you can see over here is, the most important part, again coming back, is how we triage which high-risk HPV positive women need further evaluation. And there are a number of options, and I will refer to some of them in this talk, including HPV genotyping, P16, P67, and the 3Q gain. So, most of you, or some of you, this is a schema as to the cervical oncogenesis. By no means is all inclusive, by no means it actually represents everything that happens, but it actually gives us a sequence of what we usually see following an HPV infection. So we have the infection. If it says cytosolic, then it doesn't integrate. These are the type of infections that usually clear up and within 24 months. But if it integrates, then it sets off a cascade of events, which results in invasive cancer. And that, the first step is the overexpression of the two early oncogenes in HPV, P67. And those act as they bind on P16, which is a cell cycle regulator, and in turn, they further inactivate P53 and RB. And these are the two genes that control cell division. So if they get repressed, then you have more or less an dysregulation of cell cycle. And that is what is actually happening. This dysregulation, I don't know if there is anything in between those two steps, but it results in an amplification or gain in a specific region of chromosome 3, the long arm of chromosome 3. It's, that contains several genes as potential candidates, but one of the genes that is actually quite interesting is the gene that is encoding for the terminal RNA polymerase, which more or less has something to do with the integration of the viral genome into the host genome. Now, this event is the last irreversible genetic somatic change before it actually progresses to cervical cancer. Now, I mentioned before about different tests or modalities to stratify risk, and one of which is the genotyping. As you heard from Dr. Hoda, 16 HPV 16 and 18 account for, in this country, for probably about 8% of cervical cancer or something like that. And so if we take the screen positive women from HPV, it's about 8%. Here you see, and this is in age groups and so on, you see here that the combined prevalence of 16 and 18 is about 1.5%. So one way of attempting risk stratification is through genotyping of high-risk HPV. So that is one way that has been suggested, has been proposed. And in fact, one of the products that are out there, I think, is the Cervista product. It has a special, or it has a reflex test that deals with 16-18 genotype. So that is one way of more or less assessing or stratifying risk in HPV positive cases. The second one is P16, and several of you here, the pathologists, know what the P16 stain. As I said before, as you saw in the schema, is the prototypic marker, and it's always upregulated when you have high-risk HPV-induced neoplasia. Okay. If you combine P16 with Ki67, okay, which is a proliferation marker, you can actually get a very good predictor as to what is happening in a case that is high-risk positive HPV. And that is data from a paper that was published in 2011. It was a multi-site study which actually showed here the relative sensitivity and specificity of the combined P16 Ki67 versus high-risk HPV. So as you can see, although the sensitivity it's more or less about the same, where you gain is in specificity. Okay. And it varies from 44%, from 72% up to 86%. So this is the results of one study, and I just put that there to indicate that P16 Ki67 could be used, or at least has been proposed, as a way to stratify risk in high-risk positive HPV. Another marker is 3Q gain, and this is something which I have spent a fair amount of time the last few years working on. And again, as I said, is the marker that has been found in virtually 100% of invasive carcinoma. And this is early studies as early as 1997, which were comparative genome hybridization, and you saw several areas of the genome that were consistently identified in cases of cervical cancer, but the amplification or the gain in 3Q was the most consistent one. We're talking about the region that is between 5 to 600 kb, and as I said, contains several gene loci, some of which are involved in cell cycle regulation. So we have developed a fish-based assay to assess 3Q gain, and FISH stands for fluorescence insulin hybridization. And this assay can be actually used both in cytology but also in tissue sections. And what you see here is you see an assay that has two probes. One is the 3Q, which is the disease-specific probe, and the second one is a control, which is a centrometric control. And clearly, what I'm showing you here is the composite image of a cell that has definite amplification of 3Q. And this is actually, we can count several copies of 3qa. Now, there are several studies that have been done to actually demonstrate what is the sensitivity and specificity of detecting SYN3, which is a high-grade dysplasia, using 3qa. And that's one recent study that was presented by Tom Wright at the ASCCP meeting in this year. And as you can see here, it gives you a very good specificity and positive predictive value. And this is a study that is being expanded to include additional cases. But at the first pass, it actually is a good discriminator between SYN3 and normal. Here is the table, the results from another study. In fact, there are 3 different studies that have been done to show what is the predictive value of 3qa in predicting progression or regression. And those studies were done again in cervical smears. And one of the early studies showed that you have actually a very strong negative predictive value in that admittedly small population which have been followed for up to 48 months. Here is another study which again is along the same theme that is in press in the International Journal of Gynecological Cancer. And it actually, again, the thing here is that it shows very strong negative predictive value. The average time of follow-up in this study was 28 months. Another important aspect is that the regression in these positive cases was statistically significant, different, lower than in non-regressors. And that is a very important piece of information. There is yet another study that is in press, which again shows that this is a test with very high negative predictive value. And more or less, the sum total of those studies points out to the direction that in addition to having a good, using the 3qa as a good baseline triage, you can also use the 3qa as a predictor or progression or actually regression in low-grade lesions or HPV positive cases. There is a large prospective trial, FDA trial, that is currently underway, and we expect to get that information and have the dossier ready by 2013, the end of 2013. Now, again, this is a table from a paper that was from Karolinska and was published in 2009 in the American Journal of Pathology. And there they compared different markers. And the reason of putting this up there, this table, is to actually highlight the fact that we have, sorry, so we have a variety of markers that are evolving, which we can use for risk stratification, because this is where it is going. Any kind of primary screening test that we use, be that cytology, be that HPV, it's going to generate a substantive number of screen-positive tests. We need to determine which one of those are going to progress and which one of those are not going to progress. And therefore will allow us to fine-tune the management of those women. In summary, the 3Q gain that I showed you some data, it's an irreversible genetic marker reflecting how the host, the woman, has reacted to an HPV infection. It's present in all cases of invasive cervical cancer, and we believe it is evolving to be a robust marker for triaging high-risk HPV positive cases. So I would like to stop here and thank you very much for your attention.